Uh, Regarding flexor tendon injuries, I will make a short comprehensive audio message. First, we should consider some important aspects of anatomy. Regarding the flexor digitorum superficialis, basically it is a muscle which is arising from two heads and is traveling in the forearm in the superficial compartment and is traveling through the carpal tunnel. In the carpal tunnel, the long and the ring finger tendons is superficial to the index and the small finger tendons. Remember that 25% of the population will not have any FDS tendon to the small finger. FDS is volar to FDP and divides to allow FDP to pass through them. And this split is called camphor chiasm. The splitted FDS inserts at a proximal volar surface of the middle phalanx. FDS is supplied by median nerve and acts in the flexion of the proximal interphalangeal joint in the index, long, ring, and the small fingers. Now, considering flexor digitorum profundus, it arises from the ulna, proximal third of ulna and interosseous membrane, travel in deep volar compartment of the forearm under the FDS and through the carpal tunnel. They split FDS and insert to the volar base of the distal phalanx. It has a dual nerve supply. The nerve supply is basically the ulnar half of the belly is supplied by the ulnar nerve, and it gives tendon to the small and the ring finger, while the radial aspect of the belly is supplied by the anterior interosseous nerve and is supplying the tendons to the index and the long finger. Remember that FDP is flexor of the DIP, as well as it assists in the flexion of the PIP and MCP. Regarding the flexor pollicis longus, it originates from the radius and the interosseous membrane. It is a deep muscle. In the forearm, it is at the level of FDP and lateral to it. The structure which is between FPL and FDP is the anterior interosseous nerve and artery. FPL is most radial structure in carpal tunnel. Insert to the distal phalanx of the thumb and is supplied by anterior interosseous nerve. And FPL acts as a thumb flexor. So every digit has an intricate pulley system. What is the function of pulley systems? It avoids bowstringing during finger flexion. These are actually fibro-osseous tunnels through which a tendon travels. Proximal to distal, an odd pulley is over the joint, while the even pulley is over the shaft. I will repeat it again. The odd pulley is over the joint, while the even pulley is over the phalangeal shaft. So A1 is over MCP, A3 is over PIP, A5 is over DIP. These actually arise from the volar plate of the respective joints. One important disease association, A1 is associated with trigger finger, and A2 and A4 are the critical pulley systems, and over the are basically over the proximal phalanx and the middle phalanx respectively. Thumb also has a flexor pulley system. Thumb has actually two annular pulleys and one oblique pulley. The annular pulleys are A1 and A2. A1 is at the MCP and A2 is the distal aspect of the proximal phalanx. The important pulley in the thumb is basically oblique pulley, which should be safeguarded for the avoid bowstringing of FPL. Regarding any patient coming with hand trauma, you should observe the resting posture of the hand. Any loss of flexor tendon can lead to increased extension at a resting tone. You should check for the passive range of motion via tenodesis effect. Extension of the wrist would flex the fingers, and passive flexion of the wrist would extend the fingers. You should check for active range of motion as well. You should check for the neurovascular assessment as well. You should do 2-point discrimination and you should check the capillary fill as well as Allen test. Regarding the classification of flexor tendon injuries, it has been classified 100 years ago by Bonnell, probably 1918 or 19, and same principles are followed up till now. So zone 1 is a tendon injury, flexor tendon injury, which occur distal to FDS insertion. So it is basically isolated FDP injury. It's also called jersey finger, where there is avulsion of FDP tendon from the distal phalanx. Most commonly involved finger is the ring finger. Occur due to the forceful extension while FDP is contracting, and can have avulsed bony fragment or can be a ligamentous injury, isolated ligamentous injury. Typically, patient will present with a painful finger that cannot be actively flexed. In resting posture, you could see that the finger is in a slight extension. Sometimes the tendon can be palpable as well. So, what is the classification of zone 1 tendon injuries in flexor compartment? It's classified by Becker classification. Type 1 is most retracted. Type 1 is retracted to the level of the palm. Thus, it needs urgent surgical repair, generally within 1 week. Type 2 is retracted to the level of proximal interphalangeal joint. And type 3 is the one which stays near the DIP. Type 3 is basically also having a bony fragment, which limits the retraction through the pulley system. So, in exam purposes, they can ask you which one is the most urgent. One is the urgent one, and second and third are least urgent one. Regarding the treatment in acute cases, or probably less than 3 weeks, you should do a direct repair or fixation with the dorsal button through the distal phalanx. For chronic injuries in zone 1, a silicone implant can be used. A silicone sheath is implanted in stage 1, which produces pseudo sheath, and in second stage, a graft can be threaded through the pseudo sheath and attached to the distal stump. How much can you advance a zone 1 tendon injury? It should be always less than 1 centimeter. Why? Because of Padraig Effect. What is Padraig? Actually, FDP of the long, ring and the small finger share common belly. If one of the tendons is shortened, then the excursion distance required to full flexion is reduced. This will cause complete flexion of that digit, while the other digit will be not completely flexed, or while will be on the process of flexing. So the patient won't be able to make a fist. How you treat Padraig Effect? Mostly patients are observed if in severe cases where the patient cannot produce a fist, the adhesions of the FDP can be removed or FDP should be released. Regarding the zone 2 injuries, actually it is the danger zone or no man's land. It was previously called no man's land. Now have improved outcomes. The zone is from distal palmar crease to the FDS insertion at the midpoint of the middle phalanx. I will repeat it. Distal palmar crease to the FDS insertion at the midpoint of the middle phalanx. The issue in this zone is complicated because of pulley system and the ligamentous structures. FDS and FDP both are present and both are in the sheath. There is a tight space, adhesion is common, stiffness is common. Nowadays, many surgeons advocate that in early cases, they repair FDP, they repair one slip of FDS, and initiate early range of motion protocol. They consider that the single slip of FDS plus FDP has improved results instead of repairing both the tendons completely. Zone 3 is the palm to distal edge of the carpal tunnel tendon. I will again repeat, zone 3 is palm to the distal edge of the carpal tunnel, and these are often associated with neurovascular injuries and the injury to the palmar arches. Zone 4 is a zone for carpal tunnel. Zone 4-5 is proximal to the wrist within the forearm. So any flexor tendon injuries which is more than 60% of the diameter needs repair. If the tendon is less than 60% of the tendon is injured and there is no triggering, the patient can be treated by the wound care, occupational therapy, and early range of motion. If there is a triggering or the laceration is more than 60% of the thickness, it should undergo primary repair. Tendon repair should be done as soon as possible to decrease the tendon retraction. The results in zone 2, if early repair is possible, are optimal. Prefer to be operated within 2 weeks for a tendon repair. When approaching the finger creases, an oblique fascial incision should be given to prevent scar formation, which could lead to scar formation as well as adhesion formation and flexion contracture. In zone 2, you should preserve pulley of A2 and A4 or reconstruct any of it. The strength of your repair is directly proportional to the number of strands crossing the repair site. Goal is to have strong enough repair to allow early range of motion protocol, which normally needs 4 to 6 strands. So remember that early range of motion protocol, early active range of motion protocol needs 4 to 6 strands. They are basically deep sutures 10 mm from the laceration with a locking loop is ideal. Epitendinous sutures, which are basically continuous sutures, give additional strength of about 20% and also improves the tendon glide in experimental cases. Regarding the histological repair, it has 3 phases. Inflammatory phase, which is from 0 to 5 days, fibroblastic phase, 5 to 28 days, and remodeling phase, which is after 28 days. In the inflammatory phase, the macrophages, neutrophils, and fibroblasts come to the repair site. In the fibroblastic phase, the fibroblast produces collagen. And the remodeling phase, there is an organization of collagens. When is the tendon, your repair, weakest? It is from week 1 to week 3, or day 6 to day 22, it is the weakest. Remember that the blood supply of a tendon, which are in the tendon sheath, is excellent. Actually, it is by diffusion from the synovial sheath, while those which are outside are supplied by a dedicated vascular supply. So flexor tendons, diffusion is from nourished by diffusion from synovium, and there is a dedicated blood supply from vincula, which arise from the common digital artery. In case of chronic injuries, like more than 6 weeks old, or where the tendon is retracted, or there are adhesions, or failed primary repair, the next step is for tendon reconstruction. Typically, it consists of 2 stages. Stage 1, basically a silicone rod is implanted instead of biological graft. That is left in place for 3 to 4 months for the formation of pseudosheath. Normally, if the pulley system is not available in zone 2, pulley system reconstruction is done over the silicone rods. After 3 to 4 months, the patient is again shifted to the operative room. The tendon graft is threaded through the pseudosheath, reconnecting to the distal and the proximal tendon stuffs. Normally, palmaris longus or plantaris can be used. Regarding the post-operative protocol, remember that improvement in the repair in the flexor tendons last 4 decades is not due to our surgical techniques, but instead surgical post-operative protocols. Controlled early mobilization during the post-operative protocol has been advocated, and it is one of the best for most of the cases. Early motion actually improves strength of the tendon healing and reduce the risk of tendon adhesions. The post-operative protocol limits the tension across the repair site while allowing tendon to have a high amount of excursion and gliding distance. There are multiple number of protocols which can be checked in the books, but actually in our exam settings, the three most common protocols are Durant protocol, Plinert protocol, and early active motion protocol. There are many others. If you know them, that's good, like Strickland. And but if in exam settings, if you remember these three, that's enough. So what is Plinert? Actually, patient is placed in a dorsal block splint. Wrist is in 45-degree extension unless the transverse carpal ligament is repaired. So it's 45-degree of extension of the wrist. Elastic bands are attached to the fingers and volar forearm. This allows patient to do active extension and passive flexion with the elastic when the elastic bands recoil. This is called Klinert's protocol. So what is Durant's protocol? This needs a more active, compliant patient. Patient uses the other hand to passively flex the fingers of the hand and then actively extend the fingers and flex the wrist, which provides tendon excursion and decrease the force at the repair site. Both protocols provide low force and low excursion. Then third is the early active motion protocol. Involve place and hold exercises and exhibit more stress at the repair site, but with a more exertion distance as well. Remember that these protocols are not for children, and children are normally placed in a cast after the tendon repairs. So after this, generally I will tell you some of the scenarios which are commonly tested in exam. For example, they can ask you, there is a zone 1 tendon injury, and while the surgeon is trying to repair it, there is a deficit of more than 1 centimeter. This means that the surgeon is want you to know that whether retracting or tightening the distance by more than 1 centimeter, what will happen? So quadriga will happen. Then in zone 1 again, there can be a scenario that there is a bony fragment present. When would you like to repair? In this case, it is not an urgent repair and you can repair it because the tendon, the distal edge will be at the DIP. Then there could be a scenario that there is zone 1 tendon injury, Littbecker type 1. So he wants to know that where is the tendon available. Tendon will be retracted to the palm and it should be urgent repair. Then another scenario, zone 2. Patient came within 6 hours in a zone 2 tendon injury. What is the best thing to do? So if at the surgical table A1 and A2 and A4 pili are intact, you can do a FDP repair with 1 slip of FDS repair with optimal results. Then another scenario can come as zone 2 injury at the metacarpal phalangeal joint. This, he wants to ask if the pulley system is disrupted, what you will do. So it is a 2-stage reconstruction. You will first do the reconstruction of the pulley system and then repair the tendon. Then he can ask you a question in zone 2, 6 weeks post-injury. So in this scenario, most possibly is 2-stage is better than one single-stage operative intervention. Then he can ask you zone 3 injury. So zone 3, he wants to know that, do you know that there is a vascular injury chances and neurological deficit in such patients? So you have to discuss the Allen test of the fingers. You have to assess the digital artery and the nerve. And in this scenario, if you have a tendon injury in zone 4, He wants to know about the carpal tunnel. He wants to know about the median nerve. He wants you to know the position of the wrist after the carpal tunnel transverse carpal ligament repair and how will you repair it. Then in a scenario, it can come as a child has tendon reconstruction has been repaired. What type of post-op protocol you would like to do? So you will not write clinert or durance. It should be immobilized. Then a scenario can come up as post-op second week or 10th day. The cast was removed by the patient and now he comes on day 17 with loss of motion. This means there is re-rupture. They can even write that the patient came back to the clinic after removal of the cast after 10 days, what you will assess for. So you should suspect tendon rupture. Then there is another example scenario like post-op after 1 month, where the patient comes after 1 month, loss up during the follow-up protocol, and comes with fixed flexion deformity with no pain. This is formation of stiffness and adhesions. Then another scenario post-op, he comes after 1 month with severe pain. You should suspect infection. I hope this audio message helps you. Thank you.